it's challenging to provide education for primary care around diseases that are rare. Now, myasthenia, it's an orphan disease using our current definition of less than 200,000 patients, but there are probably closer to 130 or 150,000 myasthenia gravis patients in the country, which is not all that rare. So I think you need to make it impactful. And I think the impact here is we've got really exciting therapeutics. So the goal is not necessarily that primary care doctors are going to be directly prescribing complement inhibitors or FcRn inhibitors, but that they recognize that there are very exciting transformative therapies that are available for patients with myasthenia gravis. So it matters. This isn't some sort of esoteric thing with a treatment that's a little effective. These drugs are very, very effective. And then just clinical pearls of recognizing a patient that has double vision, droopy eyelids, trouble swallowing, variable muscle weakness, and so forth needs to be considered for myasthenia. Here's a couple simple things you can do, and here's where you can send that patient. So I think it's a great, not only a great CME grant opportunity, but I think there's also a care delivery model opportunity. And I suspect the answer to this, to be honest, is probably going to vary a bit region to region. I've worked in a couple of very different regions, and the way you might approach it in one may not be as successful as the way you might want to approach it in another. And it's complicated, right? So there are overall access issues for healthcare that are driven by insurance or finances or physical proximity. If you are if you live in South Central Virginia in a rural community and you don't have means, it's hard to get to any doctor, right? I think it's one of the things that was flagged in about, I think, 10% of our respondents was lack of faith in the health system. And so particularly when you're talking about new therapies that are hard to understand and might have some perceived risk with them, this sort of, a historical lack of faith, an understandable lack of faith in the health system can drive some of this. So there are, I think, multiple determinants. There also, I think, is probably a bias on the part of some providers in terms of for whom they're going to recommend these very expensive therapies. I was actually struck that only half of our respondents felt that race and ethnicity were drivers of healthcare disparities, because I actually think that's a very potent driver of healthcare disparities. So I think there's also an opportunity for all of us who take care of patients to take a look in the mirror and think about our own biases. And this is another opportunity for a CME grant there is sort of providing training for those of us in patient care. And then, of course, all of these things become easier if you have a framework in medical school, right, or residency program, training in health disparities. We're doing this at our organization now, where we're both at the institutional level and at the department level being much more mindful and training our residents to think about disparities. We've started doing health equity rounds where we talk about a particular issue that might create disparities in healthcare. We just did one recently on translating services. If you're caring for a patient who's not a primary English speaker and you need a translator, that creates an opportunity for significant disparities. And the same goes with our ability to train primary care doctors about certain diseases like this. It's going to be easier to do within the context of a phase in one's career where you're focusing on medical education.